This is the 12th lecture in this course on understanding ABGs, and the topic is respiratory alkalosis. The learning objective of this lecture is simply to know the differential diagnosis of a respiratory alkalosis. You may have already noticed that this is, by a significant margin, the shortest lecture in this course. This is a consequence of the fact that among the 5 fundamental acid-base abnormalities, this differential diagnosis is the shortest, most straightforward, and requires the least amount of background physiology to understand. I went over the control of ventilation in some detail in the last lecture. If you happen to have skipped lecture 11, you may want to consider going back and watching at least the first 6 or 7 minutes. However, I will briefly review what was discussed as it relates to the upcoming differential. Control of ventilation is a complex process centered in the medullary respiratory center, which integrates neural and sensory input from throughout the body, including central and peripheral chemoreceptors, the cerebral cortex, several incompletely characterized areas in the brainstem, progesterone receptors in the CNS, and a number of chemoreceptors and mechanoreceptors in the lungs. The net consequence of this process is that increased ventilatory drive can be triggered by high PCO2, low pH, low PO2, pain, anxiety, pulmonary edema, histamine, inhalation of noxious chemicals, and high progesterone. Consider that a high PCO2 would usually be inconsistent with the presence of a respiratory alkalosis, and also consider that increasing ventilation in response to low pH isn't a primary respiratory alkalosis at all, but is rather normal respiratory compensation for a metabolic process. The remaining list in the blue box is essentially the differential diagnosis for respiratory alkalosis. To provide a different framework for these conditions, and one that's a little bit more practical, we can divide them into common and uncommon causes. I don't necessarily mean that items in the uncommon list are overall uncommon occurrences, but rather they are uncommon etiologies of a clinically relevant respiratory alkalosis. By a large margin, the most common cause of a respiratory alkalosis is hypoxemia. Of course, hypoxemia has its own rather extensive differential diagnosis, which Lecture 18 will be solely dedicated to reviewing. Almost every other cause is individually uncommon. For example, pain and anxiety, mild pulmonary edema occurring in the absence of systemic hypoxemia, and inhalation of noxious chemicals. Elevated levels of progesterone can lead to respiratory alkalosis, while elevated levels of estradiol are believed to increase the number of progesterone receptors in the CNS and can thus contribute to this mechanism. Causes of elevated progesterone include pregnancy and cirrhosis. Also on this list are various CNS lesions related to trauma, stroke, infection, or hemorrhage, and a small collection of drugs that can stimulate ventilation. These include aspirin at toxic doses, theophylline, nicotine, and doxapram, the last of which is a respiratory stimulant available as a continuous IV infusion that is rarely used to treat drug-induced respiratory depression in the ICU. One final diagnosis, which actually belongs on the common list, is pulmonary embolism, including PEs that are not associated with hypoxemia. To the best of my knowledge, it is unknown why PEs can trigger hyperventilation in the absence of hypoxemia. That is the complete differential diagnosis for respiratory alkalosis, and as you can see, it's quite short, as long as you consider all causes of hypoxemia as one group. While there is no neat or elegant algorithm to follow in order to establish a specific diagnosis, the items on this list are easily distinguished from one another on the basis of readily apparent features. In other words, a respiratory alkalosis rarely presents the diagnostic challenge that other acid-base abnormalities can. That concludes this very brief lecture on respiratory alkalosis. The next lecture will synthesize everything that has been discussed so far during this course into a general approach to acid-base analysis, including a number of examples of how to put the rules and algorithms into practice with real patients.